Okay, so this is the method of measuring of the muscle power of your upper limb, which is important in self-care. We call that activity of daily living. Okay, there are some resources and processes for learning, and right now we have many programs like apps in iPhone or in your tablet, or we call that ambulation devices and activity of daily living and for learning. These are the free apps we can see, like translation. So you can use the translation app to translate whatever you like. Okay, this is the processes and resources for play or amusement, like a train with bigger handle to train your hand function. And these are the emulation aid like a wheelchair or power assisted devices, like a motorcycle or for disability or for children and adolescents with special needs. And these resources and processes can help to improve our activity of daily living. And in our government, we have the official website for the resources of these instruments, which can be easily found in internet. Okay, there are some also many other companies are providing the resources and processes for the children and adolescents. Among them are the walking aid or sitting aid or wrist protect or some resources like this way. Okay, now I'm going to show you how to use the car seat. If you are interested, there are many expos of the processes and the resources for the children with special needs. As we can know, there are many expos every year. You can, if you are interested, you can search the net and know the schedule. Okay. Okay. Here's are the most important chapter, I think, in the children with special needs, which is the limb deficiencies. There are many kinds of limb deficiencies in children or adolescents. Among them, the congenital limb deficiency can easily be diagnosed and found while in our clinic. The etiology of congenital limb deficiency is the failure of formation of the part of the limb while in the uterus, in the limb bud, which is proximal to distal limb development during gestation. You can see the limb bud is formed like this way and to this way from proximal to distal during gestation age. If there are some problems during the pregnant gestation period, there might be some deficiency of the limb. Among them, we can know that almost all of them are coming from the first trimester, which is the formation of mesodermal formation is influenced at the date of 26 of gestation. And the limb bud will continue to differentiate until 8 weeks of gestation, so that in the early stages of gestation, which is very important. For example, if the mother of the mother experienced some medical problems during pregnancy of the first 8 weeks of gestation, there might be some congenital limb deficiency thereafter, like the thalidomide. Thalidomide is the medication which is often used in the early years, like 50s, for the pregnant woman to stop their vomiting and nausea. And after the medication, there see many babies, many newborns will come with limb deficiency. So that thalidomide was terminated to use for a period of time, but nowadays it is used for the cancer treatment. It is used for the anti-neoplastic medications. So that if we are using this medication nowadays, we should pay more attention about the pregnancy status of the patient. Okay, this is the thalidomide. And another one is the maternal diabetes. You can see there is a group of patients which will get diabetes during pregnancy. We call that maternal diabetes. If the blood sugar is not controlled well during the pregnancy, there might be congenital limb deficiency thereafter. And the third condition is we call that fetal alcohol syndrome. Why we call the fetal alcohol syndrome? Fetal alcohol syndrome is not the fetus with alcohol, but the pregnant mother or the mother drink too much alcohol while pregnancy. So we know that the fetal alcohol syndrome can also cause some congenital limb deficiency, which I will demonstrate you later. Okay. So the incidence of the congenital limb deficiency overall, including upper and the lower limb, the congenital is about limb deficiency. Congenital accounts for 60%, and acquired is about 40%. The average, the incidence is about 5 to 9.6 per 10,000 live births, and it accounts for the 6% of all birth defects. Among them, we can see upper limb is much more than the lower limb. The ratio is about 2 to 1, or 2 to 1. And this week, we will focused on the upper limb deficiency. And the next week, we will discuss about the lower limb deficiency. As for the upper limb deficiency, the unilateral, which means one side of the upper limb deficiency, about 50%, one half of the cases are the unilateral. And as for the lower limb, is about 27%. The multiple limbs is about a quarter, about 24%. So that this is the a very important message. All of them, the congenital deficiency accounts for the 40% of the limb deficiency is the depth transverse radial. This is the very important. If we have exam depth transverse radial, you can memorize it, and we will discuss later. Okay, depth transverse radial. And these are the upper limb deficiencies. Some important notes. The incidence about upper limb is about 4.1 per 10,000 live births. Most of them are with no hereditary implications, which is very important because in the newborn clinic, in our clinic, most mother or father, most parents, if they have a baby with a limb deficiency, they will feel very frustrated. And the next question he will ask the medical staff is that, is there any possible other hereditary complications for this limb deficiency baby? We can inform them right now that most cases have no other hereditary implications. But everything comes with an exception. There are 3 exceptions we can pay more attention if the baby have a limb deficiency. What is the exception? 3 exceptions. three exceptions. The exceptions one, if the deficiency that involve hands and feet, if you see the patients or the baby have the deficiency like hand and feet, then you should consider more about the possible hereditary implication, which I will tell you later about 6 common diseases for the hereditary implications. And another one is the central ray deficiency. What is the central ray? You can see that the line of the digit, each line of the digit is the one ray, the first ray and the second ray, the third ray, the fourth ray, the fifth ray. What is the central ray? Central ray always means that the second and the third, especially. If the patient, the baby, you see the limb deficiency is mainly in the second or the third ray of the upper limb, then you should consider there might be some hereditary complications. Okay, so the third one is the adactyly involving the first 4 digits and with the fifth intact. What does that mean? If you see a baby with congenital limb deficiency, you can only see he or she has only the little finger intact, and the other 4 fingers is absent or impaired. If you see that condition, you should consider there might be some other hereditary complications. Okay, these are the 3 exceptions. These are the 3 exceptions for the upper limb deficiency. One is the deficiency involving upper limb and lower limb, hand and feet. And the second one is the central ray deficiency. The second and the third digit is absent. And the third one is that the fifth finger remains intact and the fourth and the first 4 digits are absent. We call that adactyly. Okay. So there are some anomalies associated comes with limb deficiency. What is that? We call that the craniofacial anomalies. In fact, in our clinic, many parents will first notice the craniofacial anomalies, then the limb deficiency. It is our experiences. So that identification of proper craniofacial anomalies, which one is not normal, it should be observed with the limb deficiency together. Okay, this is the important note of upper extremity deficiency. And there are 3 systems of classification of limb deficiency. The ISPO classification system, the International Society for Prosthetics and Orthosis. The ISPO is most preferred classification system nowadays. And the second one is the original, we call that a classic classification. And the third one is the French classification, which is often used and classified in European countries in the early times. So that if you read the textbook about the deficiency, the upper limb or lower limb deficiency textbook from many in the library, you can notice that the classification is quite different. For example, if the book is older enough, you can see the classification is often the classical, we call that original, like this one. And if you are reading textbooks from European countries, you will notice that they are using the French classification. But nowadays, recent tense, we are using the ISPO classification systems. Okay, so if you are using or communicating with other medical staff or other medical professionals, it is suggested that you can use the ISPO classification system. But if you are reading the textbook or the medical record in the old times, you will see the classic classification and French classification systems. Okay, right now we will introduce these 3 classification systems to you this time. The ISPO, which classification, we also know that it is most popular and most preferred systems that classify the limb deficiency. We call that the transverse and longitudinal. The transverse deficiency means that there is no distal remaining portions, which one is the proximal is preserved, but the distal is absent. And the transverse level is named after the segment beyond which there is no skeleton portion. What does that mean? We call that the transverse level. We call that if the transverse area is below the elbow, we call that the below elbow. But if the lesion is above the elbow, we call that above elbow AE and BE. So that this definition is by the beyond which there is no skeletal portion. The longitudinal deficiency names the bones that are affected. You can see it is easily understand that if the deficiency in this bone, or we call that the radial deficiency, it is easy to understand compared to the next two classification systems. So the ISPO system is that why so popular and so preferred in nowadays. And you can see there is original classifications like this way. Normally, in the old times, when I teach this class to our students, all of them are starting to yawn because you can see there are many spatial names like archivaria, adactyly, amenia, aphalangia, meromelia, hemimelia, and phocomelia. Sometimes people will get, our students will get confused if you are not memorizing these spatial terms very well. We can now look at them at an easier way by knowing that definition. Like, for instance, the archivaria is a missing hand or foot. Amenia is absence of a limb, like a meromelia is the partial absence. Hemimelia is the half of the limb. Like I think is the most famous one. We call that phocomelia. Phocomelia also means the seal limb, which means 海豹肢 in Mandarin. 海豹肢 Mandarin. If you notice that the seal limb or 海豹肢 in Mandarin, what medication comes in your mind? Thalidomide, right? We have just tell you before, thalidomide, which is the medication used for pregnancy period for mothers with nausea and vomiting, but is using as an anti-vomit agent. But later it was found to have caused some limb deficiency in the newborn. We call that the phocomania, the seal limb, like a flipper-like appendage attached to the trunk. But sometimes the phocolemia, if you see the seal, you notice that what is the character of the seal limb? The short limb, including what? Including webs like WEBS 那个蹼. What is web? If you see nowadays, if you see some children or newborn with limb with webs, we also call that the phocolemia. Okay? 就是说let me explain in Mandarin again. It's an important concept. 就是说以前我们怎么知道说这个是有海豹肢？什么是海豹？它肢体是短的，是海豹。以前说海豹肢，但海豹肢大家都知道，海豹肢另外一个定义是什么？它有蹼。它有蹼，就是有时候小朋友生起来，他手是一样长的，但是你打开的时候，你会发现，他大拇指跟第二指或第二指跟第三指有蹼。这个时候我们还是叫做 phocomania， 这样知道吗？What I'm describing that in the classical situation, if you see a newborn with a short limb, we will think of phocolemia at once. But nowadays, the definition is that if you are seeing the newborn with a normal upper limb, but it has web between his fingers, like the first and second, and the index and the third finger, there is some web in the digit, between the digit. We also like flipper-like appendage. We also name that the focolemia. OK， 好，这就是我们的definition is the definition. OK， so the French classification describe deficiency that terminal that means that the distant the distal extremity is completely lost. If the absent in the mediate on proximal and the medial part, on proximal and distal part is the absence, we call that intercalary or intercalary. This definition or this classification, we also divided them to horizontal and longitudinal deficit. Okay, these are the important terminology of the classical classification system. You can see there intercalary deficiency, transverse longitudinal, like the preaxial, postaxial, ray, and the central and the rudimental. Ray means that the digit. If we have 5 rays in our upper limb, the first ray, the second ray, the third ray, the fourth ray, the fifth ray. If the ray is lost, we call that the lost ray. Lost the fifth ray or lost the third ray. Okay, so that the rudimentary is the remnant of the osseous element, which means the remaining part of the upper limb, Okay, so that is the French classification system. In the old times, we usually have these pictures to tell our students how to compare this classic system and the French system. For example, you can see the dark area means the lost limb. If the patient is with this right upper limb lost, we call it a mania. This one is the preaxial and axial. So you can see if the lost area is the right side of the upper limb involving radial bone, we call that radial 1 and 2. Radial 1 and 2. And if you see the patient is only lost his radial bone, we call that longitudinal radial. If the patient loses his ulnar bone, we call it longitudinal ulnar. Okay, so this is the French or classic classification of the lost limb of upper limb. Okay, this is the French, and already we call that French classification systems. Okay, these are the common scene of limb deficiency, like this one. The dark area means the lost area. This is the complete absence of limb. And this one is intercalary defect. And this one, we call that the terminal transverse defect. The terminal, and this part of the limb, we call that terminal transverse defect. And this one is the longitudinal defect, like radius and the first and the second digit, which is also called preaxial in classic classification system. As for the figure F, this is longitudinal defect. This is the preaxial, this is the postaxial. And this one is the longitudinal pre and postaxial, or postaxial. For example, if this patient have the loss of his first and the second limb and the fourth and the fifth limbs, we can also call that this is the longitudinal loss of the pre and the postaxial of digit. We can also say that it has the rudimentary of what? The third finger. Okay, so this one is the longitudinal pre and postaxial, which is also, we can call that rudimental third, which ones it is only remaining the third finger, the middle finger. Okay, so it is the major groups of upper congenital limb deficiencies. Okay, and this will be discussed next week. These are the major group of lower congenital limb deficiency, which we'll discuss the next week with you people. Okay, So that these are the comparison table of the common deficiency named by three classification systems. You can see the ISPO, which is the most favorable one, and the French and the classic classification system. For example, if the patient have upper extremity anemia, which means that in ISPO system, we call that what? The transverse upper arm total. In the French system, we call that the terminal transverse. Okay. For example, is the people, the newborn with the mother taking thalidomide while pregnancy, he has upper extremity foconemia. In the French classification system, we call that complete upper extremity foconemia, or we can also call that the distal absent of radius ulna or proximal absent of humerus, which can be seen in the French system. As for the ISPO system, you can see that there is a longitudinal humerus radial or ulna total loss. Or if the patient loses his carpal bone, metacarpal phalangeal bones, we can also note that in ISPO system that carpal, metacarpal, phalangeal, partial or totally lost. Okay, so these are the three different classification systems, which can be compared by this table. This is the easy comparison table of these three classification systems. Okay, there are some syndromes. There are some syndromes commonly associated with limb deficiency, which is very important if you are going to master the classes in congenital deficiencies or congenital malformations or congenital malformations. These are the common syndromes with limb deficiency. There are several of them. Among them, the TAR syndrome, like the Fanconi syndrome, or the Holt-Oram syndrome, the Bader-Gerold syndrome, or Vectoral syndrome, which I can introduce you later one by one. Okay, this is the TAR syndrome. What is the TAR syndrome? TAR syndrome is the acronym abbreviation of thrombocytopenia with absent or radius. So many of them can be early diagnosed with the pregnancy, the test during pregnancy. Then we can do some genetic test for the monogenic cause of limb deficiency. For example, Fanconi anemia or Holt-Oram syndrome, we can check these associated genes for the early diagnosis. Okay, these are the common syndrome with limb deficiency. Is TAR syndrome. TAR syndrome is what? Is the thrombocytopenia or absent radius syndrome. The radius syndrome, we call that TAR, absent radius. Absent radius means that there is only loss of radius bone, but the thumb, and the fingers remains intact. The radial aplasia. And during pregnancy, if you are doing some genetic test, you can see the baby with TAR syndrome, it will comes with thrombocytopenia, and in that case, there is a risk for intracranial hemorrhage for the first year. And these children will have show status for some skeletal abnormalities, especially in the radius or loss of radius. And some of them will have heart and kidney deficit, and micrognathia, prominent forehead, and lost ears. And some of them will demonstrate the cow's milk allergy. Cow's milk allergy is common seen in Asian children, Asian babies, but is not normally seen in Caucasian or African babies. So this is the early warning sign for the Caucasian or African babies, but not early sign for Asian babies. Cow's milk allergy. Okay. And the second one is the Fanconi pancytopenia syndrome. And the Fanconi pancytopenia syndrome, which is demonstrated by the radial abnormalities, like loss of his radial bone. But among them, we can also notice that during blood test, we can see the pancytopenia. There is some eye abnormalities like malformed eye ears or hearing loss, or malformations of reproductive system, including kidney or absent kidney. There was some brain or spinal cord, or like hydrocephalus or microcephaly, or have heart defects. And this another one is the Holt-Oram syndrome. We call the cardiac limb syndrome. Holt-Oram syndrome, including the limb deficiency as well as like heart problems. And in these cases, the patient was suffering from loss of couple bones, like wrist bone abnormalities. They were lost thumb or long thumb, looks like a finger. You can see this finger looks like missing someone, or missing somebody, missing the long thumb. And this patient will also have some cardiac or heart problems like atrial septal defect or ventricle septal defect, which can easily seen in the newborn. Some of them will have some conduction abnormalities, like a premature beat. Okay, this is another one. We call that the Baylor-Gerould syndrome. Baylor-Gerould syndrome is also called the cranial synostosis radial aplasia. What is the cranial synostosis? Which is the premature fusion of bone in the skull, especially in the sagittal fissure, like this one. Coronary fissure. Coronary fissures, cranial synostosis will make the head looks like a very strange shape, We call them the brachycephaly, brachycephaly 就看起来头比较短，small or short head like this one. And this patient will also demonstrate the loss of radius and couple bones. And with oligodactyly, which means that you can see there is a little finger. There's only 4 fingers in his hand, and there is 3 fingers actually. There is 3 fingers are fusing together, so we call that oligodactyly. And among them, a radial ray deficiency. Radial ray deficiency means that there is a loss of radial bone, including the thumb, including some. We call that radial ray deficiency, which is the Baylor-Gerould syndrome. And the last one is the vectoral association. We call that vectoral syndrome or vectoral association. Vectoral syndrome is a group of syndromes that with different clinical features that the patient will have the vertebral defect, the loss of growth in vertebra and in the spine, and the anal atresia. Anal atresia means there is no penetration or absent of his anal fissure. There's anal atresia. So many of them are being found during delivery with no anus. With no anus, we call that anal atresia. And some of them have congenital heart problems. And the tracheoesophageal fistula, which will make the patient very suffering to swallowing and very easy to get a pneumonia while feeding. And like esophageal atresia. Esophageal atresia will also have some swallowing problems. And renal anomalies. Among them, you can see again, there is a limb hypoplasia or aplasia, which means that there is no or little radial bone while birth. And some of the patients will have single umbilical artery, which that will make the baby turn blue while delivery. How to confirm this diagnosis? If you have seen 3 of the features clinically, you can have the definite diagnosis. the inheritance is sporadic, so that we can see from the beginning, we have told you that if you notice that the patient have a limb deficiency, most of them are not associated with congenital anomalies, but with 3 exceptions we have told you before. Like this patient have the VSD, ventricular septal defect, about the intelligence, luckily, most of the patients have normal intelligence or normal intelligence. Okay. Okay. This one is, we call that the EEC syndrome. EEC syndrome is the ectodermal dysplasia cleft syndrome. We can see that this newborn baby have cleft lip or cleft palate during birth. After that, we will not notice the normal growth of teeth thereafter. And this is the most iconic features of EEC syndrome. You can see the fingers like only 2 rays of the fingers. We call that radial aplasia. The thumb is also present, but there is no presentation or no growth of his 3rd finger, which means that the middle finger, ectodactyly. So we call it EEC syndrome. This patient will also have a thrombocytopenia for the first year, associated with heart and kidney defects. Okay, among these people, among these children, we have noticed many times that there is a retrognathia or micrognathia. What is the retrognathia or micrognathia? Retrognathia means there is retraction, the backward contraction of his lower jaw. We call it retrognathia. Retrognathia, you can see, the patient has a retro or drawing back of her lower jaw. 它的下颚是小的，是往后缩的。那小寒呢？What is the micrognathia? Micrognathia means there is small of his jawbone. Okay. What is the difference? This one, retro, means the lower jaw is normal, but it's retraction. But micro is small, micrognathia. Micrognathia. What is the importance of this clinical feature? This micro or retrognathia or micrognathia will cause major or serious heart problem, swallowing, and speech problems. Okay, we have discussed last semester. We have talked to you discussing about swallowing and speech problems. That right? Actually, the patient with micro or retrognathia is very commonly seen in our clinic, in every clinic. Which one is like this way? This one is the retrognathia, and this one is micrognathia. OK， 这个就是我们说下颚比较回缩retrognathia。我们台湾话叫什么？后倒which means 后倒 in Taiwanese, and micrognathia is this way. Micrognathia is this way. You can see from the lateral side, the patient's lower jaw is small, so that you can easily find there are many cases in our normal life. You can see patient with this one, retrognathia or micrognathia. Okay, which we call that there was some swallowing and speech problems. And in the hospital, there will be some problem while you are doing some intubation. If you are doing surgeries, most of them we have anesthesia, and during that moment we have to intubate the patient. If you intubate the patient with micrognathia or retrognathia, you will encounter many difficulties. So that the anesthesia doctors and the surgeons are very concerning about this condition if you are performing surgeries for these patients. Okay. And another one is the fetal alcohol syndrome, which that the mother has too many alcohol during pregnancy and will affecting his baby after birth. Okay, this is the phase of fetal alcohol syndrome. You can see in a young child, we call that this is the discriminating features. Discriminating features. What is the discriminating? We call that facial dysmorphism. What is facial dysmorphism? You see the face of the baby, you notice at once it's not alright. It's not right. His face is very straight. His face is straight, but you can tell what strength it is. We call that facial dysmorphism. 就看起来怪怪的 facial dysmorphism. We can see one item by one item to see what is facial dysmorphism. This is the facial dysmorphism. We call that no nasal bridge. Which means 纳皮in Chinese 就是鼻子塌下去鼻子塌下去Nasal bridge is low, and the epicantral fold is more. Epicantral fold is more like this way. And we call that the distance between eyes is wide. 眼间距变宽 the wide distance between faces, and the short nose and the short nose, and the flat mid face. The mid face is that the area between the cheeks, the here mid face is flat, and the ear is minor, small ears, like we call that the ear like the mouth, 好像那个老鼠 like a rat, like rat, and there is the upper limb is thinner. There's thin upper limb, and the micrognathia is the fetal alcohol syndrome, right? Okay, so this is not normal in the Caucasian baby. You can see in the Caucasian baby, they have two the palpebral features. Normally, they will have not short palpebral features, and their nose is higher. And the epicantral fold and the facial fold is thinner. So that if you see this feature in the Caucasian or African baby, you can know at once it is not normal. But in Asian babies, some of them are looking like this one, So that the most important the features is that the distance between the eyes 就是我们说眼间距 the distance between the eyes is wider. If you notice that, and the thin upper lip, if you notice that there is a wider distance between his eyes or her eyes, and there is thin upper lip, if you see this baby looks like small and long face like a little monkey. What we said that in Taiwanese is 高高 看起来就是 look 高高 If you see that looks like monkey boy, and the distance between eyes is wide, and the upper lip is thin, you should notice that you should be alert at once that baby might have fetal alcohol syndrome. Okay, this is we call that fetal alcohol syndrome. 胎儿酒精症候群 Okay, as for the micrognathia and the retrognathia and the fetal alcohol syndrome, which we call that is have some problems in swallowing and in speech, and in some we will have some problem in surgery while you have to do intubation in surgery. There is a score we are commonly used to measure if the patient is not suitable, if it is suitable or not for intubation. We call that Malapati score. Malapati score is the score which is invented by an Indian anesthetic doctor, which calls the Malapati. Malapati, he divided the 可以直接去上厕所没关系 the oral area into 4 stages, and all of them you can see by yourself with the iPhone or mirror. to see what is the Malaparte score of your current status. Okay, in the first class, the stage 1, the class 1, you can easily see there is a uvula and pillars and half and soft plate and your tongue while wide opening your mouth. You can open your mouth as wide as possible and see from a mirror or from your colleagues to see if you can see these components. If you can see the pillar, uvula, soft and hard plate, and tongue, and like this way, we can say that the Malaparte score is 1. And the second one, you can see the uvula is connecting to the tongue, to the base of tongue. We call it classic 2. But if you cannot see the uvula while wide opening your mouth, this is the class 3. And class 4, if you open your mouth wide enough, but you cannot see the fissure or dark area below or beside the uvula, we call that the class 4. Okay, so if you are in the class 3 or class 4, the soft palate is not visible at all. Or class 3, you can see the base of the uvula if you are in the class 3 or class 4, which means that you are not suitable for intubation. Okay, which also means that you might have some problem of obstructive sleep apnea during sleep. OK， 好，这个我再讲一遍了哈。这个就是说，如果你是1跟2的话，是 normal 的。It's normal if you are seeing you are class 1 and class 2. But if you are class 3 or class 4, whatever you are, retrognathia or micrognathia or fetal alcohol syndrome, or even you are a normal person with a class 3 or class 4 in Malaparte score, which that means you might have some problem while intubation. Or recently, our research showed that there might be some obstructive sleep apnea problem in patients with class 3 or class 4 of Malaparte score. Okay? Okay, do you understand? Now, right now, we can have some 1 minute for everyone to see. You can have your score. You can have your score on Malaparte score. You can measure it by yourself or by your colleagues or by me. Okay? 好，大家可以试试看，好，来看看自己的 Malaparte score 是怎么样。Some of them might say, "Sir, I'm normal. I see normal. I will not have snoring during sleep. Or I'm not. Or I'm okay. I'm okay. I will sleep. Or I see I'm okay." But you can see that in some patients with severe flu or severe sinusitis, sometimes you will come from class 2 to class 3. 在严重感冒的病人，有时候它会变成是 Malaparte score 会变成2到变成3到变成4，这样知道吗？What is the importance of the score? If you know the patient with the class 3 or class 4, we can do some swallowing therapy for them, which we have told you last semester, to enhance their soft palate function, from making them from class 3 or class 4 into class 1 or class 2. OK， 好，这是我们上学期有讲过吞咽的软腭的训练的方法，请大家回去可以再看看就是这个东西是可以经由训练去改善，好不好？好，大家可以写一下你的 Malaparte score 是几分？好，今天就大家的第3个作业就是你的自评的What is your Malaparte score by yourself? By yourself. Okay, I think everyone get your score, right? Get your score. You can write it on the note. If you are class 1 or class 2, congratulations. You are okay by now. But you are class 3, class 4. Don't be upset. You can review the programs, the classes we have told you last semester about the soft palate strengthening exercise to make them from class 3 and 4 into class 1 and 2. Okay? 可以了哈，大家都评完了嘛哈 ，OK 好，好 ，This is the Malan-Party score Malan-Party score. Okay, this one is the Cormack-Dehaene classification system, which is also by commonly used by our anesthetic doctors and surgeons, which graded them to 1 to 4, and it is also scored for the intubation, easy. This one, grade 1 and 2 is easy for intubation, and the 3 and 4 is not good for intubation. Okay, if your patient have the Cormack-Dehaene classification 3 and 4, which is similar to the Malan-Party score 3 and 4, which in this patient they will consult a rehabilitation doctor consulting us for a soft palate training. It takes about 2 or 3 weeks for them from grade 3 and grade 4 to grade 1 and 2. Okay, this is another system in another system which we can observe the area, the widening of the epiglottis. 这是另外一个观察的这个系统。Okay. Now we are coming to the prosthetics. The prosthetics, the definition of prosthetics is the artificial substitute for a missing body part. We call that the prosthetics. As for the upper limb prosthetics, there are some reasons like congenital we have discussed in the previous sector. And the second one is the acquired upper limb amputations. Okay. As for the acquired amputations like trauma, like cancer, like vascular complication, they are all the common causes of acquired upper limb amputations. As for the trauma is the leading cause of acquired amputation in the upper limb. It accounts for the 75% in the patient from 15 to 45 years of age. And the second one is the cancer and tumors of upper limb. And sometimes there is a vascular complication like diabetes or urinary conditions causing the destruction of upper limb. We call that acquired upper limb amputations. Okay, this is the epidemiology of the traumatic amputations. We can see that like diabetes or peripheral vascular disease or trauma or tumor will cause the amputations. Recently, nowadays, the amputation from tumor and the trauma is decreasing. However, the vascular deformity, the ratio is increasing these days. For example, like diabetes, uremia. As for the congenital limb deficiency, the incidence remains constant. Okay, the risk for amputation is increased with age. Likely, the 65, the over 65, the risk is highest. Okay, what is the importance of the amputations? If the amputation is caused by the vascular disease, half of the patient, 50% of the patient will be deceased, will pass away in 5 years. The vascular deficiency causing amputation over 65 years of age is about 64. The lower amputation, which we'll discuss next week, 75 to 93% of the lower limb amputation is from the vascular disease. The African American, the risk for amputation due to vascular deficiency, vascular disease, the risk is 2 to 5 times higher than the other populations. The trauma is the major cause of upper limb amputation. We have called that. Mostly is the amputation of finger, and the male is more commonly seen in female. This is the case. We can see this is the patient of the upper limb amputation, which is using the machine to cutting paper and incidentally cutting his finger like this way. You can see 1, 2, 3. There is 3 fingers involved in the amputation. So this is common seen in our medical center, especially in Lincoln. There are many emergent operations for the amputation for the like this one. This is traumatic amputation. Okay. So let us see what upper prosthesis, upper limb prosthesis can do in a normal daily life. This is where I will show you 2 demonstration videos showing that in the adult or in the children, we are using the upper limb prosthesis for in many aspects. Okay.现在大家可以看一下，就是上肢的义肢，upper limb prosthetics. What is the usage of the upper limb prosthetics?
When the doctors first told me that they were going to have to amputate my arm, my family and I, we pretty much all agreed that we weren't going to let this stop me.
He said, there is nothing that is going to replace your hand, but we will provide you with as many tools so you can function as normally as you can function. And that was a very good message to me, because I said, I'm ready. I'm ready to do this.
Right from the beginning, I just decided I can do it. I can do whatever I want to do, and I'm not going to waste my time feeling sorry for myself. I'm going to spend that time learning how to do things differently and doing things I want to do.
Immediately after my amputation, I had a lot of phantom pain.
I could feel my hand, the hand that was amputated, and it was in a very, very tight fist.
I've dealt with less of it as time goes on.
Your brain is still communicating with this arm that isn't there. I think that's very interesting.
The prosthetist is a very important person in the whole team.
He took a casting of my residual limb and then used that to build my prosthesis.
The prosthetist has to be with you all the way and say, how is it working for you? And if it's not working well for you, what can we do to make it work better? It takes some time, but it's well worth it.
My prosthetic device is an artificial arm with a hand, and then I have a mechanical elbow, and it comes up over my shoulder, the plastic part does, and I have a strap that goes around my neck and under my arm. With my shoulders, I can open and close my hand to some extent and pick up things.
I've had a whole assortment of terminal devices that go on the end of my arm. The nice thing about the one that I use every day is that it has a large surface area for gripping, and I can also adjust how tight it grips. The hook is like my workhorse. It's rugged and it's simple. It works great for whether I'm fishing or hunting, splitting wood, or if I'm just tinkering with really small tasks. I always love it when I'm out and about and this little kid goes up and tugs on his mom or dad's pant leg and he goes, look, there's Captain Hook. And the parents will scold him and I'll look at him and I'll go, "Arr!" And it just makes the kid's day.
I'm on my 3rd major prostheses. It's not uncommon for me to perhaps change in the middle of the day. I mean, it only takes just a couple of minutes and then I'm ready to go to my next task. I learned that the company that manufactures all this prosthetic stuff, they were coming out with a new hand. It has a movable, powered thumb, so it can provide you with multiple different grips for gripping things. Plus, it looks extremely cosmetic.
The occupational therapist was extremely helpful. She gave me a positive attitude that no matter what, you can do it. We just have to meet each problem as it comes along and say, well, how can I do this differently? I went to my computer and I thought, I'm not going to be able to type like I used to type, but I type with one hand now. Like anything else, it just takes practice and your speed will come back.
I was very right-hand dominant. All my life, my left hand has just been the pusher, it's been the holder. So I had to have a little chat with my left hand saying, hey, we're going to transfer all these skills that my right hand had, and I'm going to expect you to kind of do that. And so my left hand has done just fine. The brain's ability to transfer is remarkable.
I always loved hunting and target shooting. Right away from the beginning, I figured I still want to do this. I'm going to find a way. We took some parachute cord and put a little loop on it that I could grab with my prosthesis, and I could then have more control of the gun. I was able to modify the pump on my shotgun, and that way I was able to chamber new shells into it.
I can do whatever I want to do. We had them install a steering knob on the steering wheel. There are 3 switches right below it. One is for the directional turn signals, one is for the headlights, and the other for the windshield wipers. I can drive and be independent again. That was a big thing for me.
There were people, including my family, that were watching carefully to see how I'd adapt to boating. I had to figure out a way to run the throttle, so I crafted a device. Owning a reasonably large boat is like owning a second home. There's always lots of things to do on it. It clearly is a labor of love.
I didn't really start fly fishing until I got to college and took this class and learned how to tie flies. I like fly fishing because it allows me to escape. I can go find a hidden stretch of river and get away from civilization for even just for an hour.
We started going to the stores in town that had adaptive equipment. All kinds of devices out there. You'd be surprised what they have. I have a can opener that you only have to use one hand. It opens it for you. The thing I use the most is my cutting board. It has 2 supports in the back that hold like an apple or anything I want to slice. The needlepoint frame that I have has an arm that goes down and a piece that goes under my legs, and I can do my needlepoint just fine that way. It's been interesting, and it's been a challenge and a learning experience. I don't find my handicap that serious, actually.
I don't feel handicapped at all, to be honest. I just happen to be a little changed now.
Anybody who tells me I can't do something, it's like an automatic challenge. There's nothing that should stop me. No matter what, there's a way you can get to the top.
I describe my amputation as a combination of a journey and at times a real adventure.
Okay, this is the video from the Mayo Clinic showing that how patient can survive or living well after loss of their limbs, upper limbs. We call that using the proper upper arm or upper limb orthosis can help you have a independent activity of daily living. And among them, you can see that many of them, they can use their prosthetics to read the papers and opening the jar and opening the door and opening, starting the boat and riding the car and in the car. So that we call that a pinch. Pinch power is very important. Which I have asked you to measure the power of the pinch, which I will show you later. And this one, second one, is the video. We can see that how we can help the children or adolescent with limb deficiency using prosthesis or prosthesis. Why we are using prosthesis in children and adolescents? We are helping them to rebuild their body images. They are growing up with the complete body images using prosthesis, and using the prosthesis to do the games, the playing, the activity of daily living. Okay, this is the second video. With their upper limb prosthesis. While if you are using them properly, you can use them to crawl or creep or grab something or play toys when interacting with others. All of them can help them have a better life. Okay, these are the standard level of upper limb amputation. We can see that the nomenclature of the amputation is according to the amputation area. Like if they are amputated from the digit, we call that transphalangeal. In the carpal bones, we call that the transmetacarpal and the transcarpal. And if they are cutting here, we call the wrist disarticulation. And here we call the transradial or transulnar, or we call that the below elbow, the BE below elbow. If you are elbow here, we call it elbow disarticulation. And if we are cutting from here, this is transhumeral. We will also call the above elbow, AE, above elbow amputation. And if you are going back this way, it is called the shoulder disarticulation. Okay, so it is easy to understand the level of upper limb amputation, which is that we can also see that in Mandarin, in Chinese, 这个我们就说经掌骨、经指骨、经腕骨，腕关节里段、经桡骨、肘关节里段、经肱骨、肩关节里段。那在这个地方的时候，我们可以说这个是肘下截肢，肘关节下面 below elbow disarticulation. If you are above elbow, we call that transhumeral, or call that above elbow, above AE amputation. 所以我们大家看到简写 when you see the abbreviation like the BE or AE, which means that it is below elbow or above elbow amputation. OK, 这个我想这个应该大家就比较清楚。OK, for the below elbow or above elbow amputation, there's more detailed depiction of how the amputation is performed area, like this one. if you are doing this way is the keeping the remnants 60 to 90%. We call that the standard AE. If you keep the remnants more than 50%, we call the short AE, short above elbow amputation. If you are cutting this area, we call the humeral neck. Less than 30%, we call the humeral neck amputation. As for the below elbow amputation, if you are keeping the remnants more than 55%, we call that the long BE, the long BE. And if you are keeping the remnant, the remaining part of the forearm between 35 to 55, we call that the short BE amputation, short BE amputation. If you are keeping the remnant part less than 35%, we call that the very short BE, very short BE. What is the importance? If you are keeping as long as the remnants, as long the remnants as possible, it will be easier for the hand to control the future prosthetics. Do you understand? Let me explain in Mandarin again. 就是你的残肢如果保留越长的时候，未来你使用辅具的方式，未来使用辅具的时候会越方便。What is it is what we means that if you are keeping the remnant as long as possible, it would be easier for you to control your prosthesis in the future. Okay. What is the level of the upper limb amputation important is that if you are keeping the remnants longer enough, it will be easier for you to control the prosthesis in the future. Okay. This is the comparison of the different type of amputation. Okay. How we classify these prostheses? We often classify them according to the infrastructure. What is the infrastructure? If the bone is like the inside of the prosthesis, we call that endoskeletal, 内骨骼 endoskeletal. If the fixation, the rigid part is outside in the margin of the prosthesis, we call that the exoskeletal. What is the advantage of endoskeletal prosthesis? Endoskeletal prosthesis, the items and it is universal, so that you can use different prostheses from many other countries or many other factories and using them together for endoskeletal system. As for the exoskeletal, 外骨骼 exoskeletal system, the advantage of exoskeletal prosthesis is that it can tolerate humid and chemical erosions. It is suitable for the difficulty for the extreme conditions like in the salt or in the hot water or in the humid area. It is the advantage of exoskeletal prosthesis. And there are another ways of classification of the prosthesis, like the how to drive, how to use the prosthesis. If you're using the prosthesis by the passive range of motion, we call it passive. If you are using the body, the posture of your body to drive the prosthesis, we call that the body-powered prosthesis. But nowadays, if you are using the muscle power of the remaining limb, using the muscle power or using the myoelectric signal of other muscles to drive the prosthesis, we call that externally powered, or call that electric powered prosthesis. Okay, so we can divide these prosthesis according to their energy systems. One is the passive range of motion, or using the body posture, we call the body powered. Or using the mild electrical signal from the remaining limb. We call that externally powered or electric powered prosthesis. This is also a very popular type of classification. Okay, let us see what component do we have in the normal upper limb prosthesis. This one, we call that the terminal device. Terminal device, which means you can link this device to the prosthesis to do different functions. For example, you have hook, you have fingers, you have a hammer like this way. We call that the terminal device. This one, we call that, this one is the socket. Socket is like a double wall socket, which can fit into your residual limb. We call the remnants of your limb. We call that a socket. And the elbow. For the elbow joint, you can flex and extend the socket. We call that elbow hinges and hinges. As for the shoulders, you can see there is a strap. Which can attach to your neck or to your chest, which can help to fix your upper limb prosthesis. We call that the harness. Okay. So that the terminal device and the socket and the hinge and the harness are the common seen the units in upper limb prosthesis. Okay, this is the picture of the upper limb prosthesis. We call that the terminal device and the cable to control for the terminal device, and the socket to fit it the remnant of upper limb, and the harness help to fix the whole prosthesis to your body or to your chest. Okay, this is the whole picture of the upper limb prosthesis. How do we fit the upper limb prosthesis to our body? You can wear it like putting on a backpack like this one. We call that if there is a ring between the harness, we call that ring harnesses. Once you can do, if you are wearing the upper limb prosthesis like this way, how do we use the terminal device? You can just flex and extend your chest by moving your body. You can easily have tension on this harness and have tension on this cord and have tension to make the terminal device to open. So that we call that a body-powered prosthesis. Okay. Okay, this is the upper limb prosthesis. We call that the terminal device, which also called 终端, 中气 in the Mandarin. There are many kinds of terminal devices like hook. As you can see from the motion picture, the captain hook, it looks like this way. Hook can do something like hook something out. Or mechanic hand like this way. We call that a cosmetic hand like this way. You can see the cosmetic hand is nearly, it looks very similar to the natural ones. Okay. We call that the terminal device like this one. You can see they have a hammer or hooked or double hook. How to drive them? We have said that before, that the passive terminal device, or the body powered by changing your posture, changing your position to drive the terminal device. Or recently, we have that electrical powered using the mild electrical signal from our remnants of body to drive the terminal device like this way. Okay, there is a group of terminal devices. You can see one is the tip, like the front, like the thumb, like the hook, or the double hook, we call the grip, without fingers. And then we call that non-prehensile terminal device. As for this one, you can do this position like the prehensile. We call that a prehensile, like this one, that clamp grip or finger exterior finger. You can do this. And with fingers, we can see there is a tip, there is a middle, there is a finger span, there is a thumb, there is both fingers. Like we call that the multi-contact. Okay. As for the non-prehensile and prehensile, what is the difference between the prehensile and non-prehensile terminal device? You have to make sure what the power is enough. This one, right? Prehensile muscle strength is enough. 就是这个力量要足够，这个力量要足够。这个力量是什么？这个力量是什么？ What is the power? We call that what? Grasp power. Okay, this is the grasp power. So that we have just asked you to measure your grasp power by this one. This one we call the dynamometer. Dynamometer. You can see everyone got a number of your right hand and the left hand grasp power, which can be used to design how much power do you need to using grasp something within your hook. OK， 就是说我们用这个，为什么要请大家测这个东西？为什么要测这个 grasp power？ 就是要知道说你要抓东西的时候，你需要多少力量 ？How many strengths do you need to grasp these things? OK， 这个就是 what we do for terminal device. Okay, as for the some person they have to use a bar or stick to do something like doing farm in the field. You can use the mid-shape prosthesis. And the terminal device which can be powered by body, we call the body-powered terminal devices. There are two kinds of terminal devices which we can use to drive the terminal devices by our posture. One is the open and one is closed. What is the difference? If you are using power like this way, this one is keeping closed and open. This is the voluntary opening device. And if you are doing that this way, if you are using body power like this way, the open device will be closing. We call it voluntary closing device. Okay, there are two ways of using this terminal device. Okay, this one is the myoelectric prosthesis. Myoelectric prosthesis is the newest version of upper limb prosthesis, which we can design a robotic hand. They have differential sensors within the proximal part of the prosthesis, and once you attach them to your upper limb remnants, and it will sense the muscle activity of the prosthesis and making them forming different signal to do some postures like grasping or pinching. We call that the myoelectric upper limb prosthesis. Actually, we are spending a lot of time for training persons with upper limb deficiency using their myoelectric prosthesis during our clinic. And you can see this patient is performing very well by using myoelectric hand due to the advanced technologies. You can do some fine movement like this one, rolling the keys and opening the doors, even folding the pages. You can do it by myoelectric prosthesis. We call that myoelectric hand. Okay. And this one is the traditional type of harness. If you have a ring over here, we call the ring O-ring or figure of 8 harness. You can see the harnesses just look like a figure of 8 or 7, 6, 7, 8, the figure of 8. We call the ring harnesses. And this is the figure of 9 harnesses. You can see the harness is just like a 9. It just looks like a 9. So we call that figure 9 harnesses. And this one is the chest strap with shoulder saddle. You can see the patient wearing this one, and you can do the flexion or extension or the movement of the prosthesis by moving your shoulders. So we call that chest strap with shoulder saddle. And this is the suspension system. The most commonly seen is figure of 8, and we call that O, figure of O. And this one, less commonly seen is figure of 9, figure of 9. Okay, here are some important issues of amputee care and rehabilitation. And the first one, we have to determine the level of amputation. As we have said before, the longer the amputee is remained, the easier the prosthesis will be controlled. We call that the determination of amputation level is important. And we have to do careful assessment of these muscles, because these muscle powers are important for the prosthetic control mechanism. Especially nowadays, we are using bioelectric hands, meanwhile, we have to evaluation of the general health and cognition of this patient. And general health, if you are seeing this patient with prosthesis, their general health is no different than the regular or in a common regulation. Okay, we should treat condition before fitting prosthesis like cognitive impairment or other neurologic problem. We don't hope the patient with prosthesis will hurt themselves if they have cognitive problems not corrected before the prosthesis fitting. Okay, during using of the prosthesis, we should also pay attention to if there is any bone spur in the amputation area, or is there any tender scars, or skin rashes, even defects. Among them, neuroma are of critical importance, because in the amputation, sometimes the patient will form some neuromas in the terminal area of their amputee, which will make them feel aching or tingling or even lightening sensation while fitting their prosthesis. If you are encountering these conditions, neuromas must be considered and treated. And before the prosthetic training, we should do some shrinkage of residual limb. As you can see from the video, all the people fitting the prosthesis, they are using like the socks, like the elastic bandage first, and keep them shrinkage and then fitting the socket. And the muscle strength and the range of motion is important. That's why I'm asking you to do the grasp and the pinch function before the class. And the postural problem is also important. If our patient are suffering from scoliosis or kyphosis, he or she will not perform well by using a figure of 8 of strap. So that we should also correct these problems before we are doing prosthetic training. And the desensitization is also very important. And for the traumatic amputation, the patient will feel two neurologic complications. One is the phantom sensation. What is phantom sensation? Once you have your limb cutting, you will still feel the hand is still remaining. We call that phantom sensation. You feel the hand is still there. We call that phantom sensation. after the training, we call that desensitization training, which is by the light tapping the wound and the squeezing of the residual limb gradually every time, 3 times a day, like this one. And the sensation of phantom sensation will gradually shrinkage to the amputated area. We call that desensitization. And another one is we call that phantom pain, the phantom pain. Once the patient is amputated from here, for example, he or she will sometimes experience the pain in the absent area. We call that phantom pain. As for the phantom pain, we also can do some desensitization to make them feel better while doing the prosthetic training. As for the scar, scar will be an obstacle to fitting the prosthesis, so that we can manage the scar by mobilization or using some scar removing agent modality to make them feel better while fitting the prosthesis. Like the ADL assessment or home program exercise also important. The exercise like the forearm and the humeral rotation, like this one, is also very important because there are 3 major the functions. One is the grasp function, and another one is pinch function, and the third one is forearm and humeral rotation. All these 3 can account for a successful prosthetic training. Okay, so in the training session, we should always testing and strengthening muscle of the residual limbs. How to testing, how to strengthening? I have told you before. We can test the grasp function and the pinch function and the forearm pronation and the supination. All these muscle power are important, especially if you are going to use the myoelectric prosthesis in the future. All these muscles are to be evaluated and to keep. Okay. There are some vocational issues like the terminal device can be designed in different situations, and emotional maladjustment and reduction in earning power should also be noticed, should be also be pay attention while in training. As for the emotional and the psychological issues, that it takes time for the patient or for the children to acknowledge the limb loss. So it takes different time for the patient to adjust. And sometimes the personal factor like age, sex, education, or prosthetic history and the personal preference will also influence the emotional or psychological issue. For example, we have seen from the example videos that many of the children lost their left hand. If you are right-handed, so the prosthetic training will be not a major problem for the children with right-handed. But what if the patient is left-handed? The prosthetic training, if left side, will be more harsh than the children with right-handed, right? So that personal preferences also is a factor. If you are not going well in the training process, they will encounter some emotional or psychological issues, okay, during the training, okay? Okay, so that's okay, that's the class for today, okay? And final, that's the few slides for today's class. And we call that muscle strength. As I have told you before, we can do the grasp function and the pinch function, okay? This is the measurement of the muscle power for grasping. Okay, so the gentlemen can see the grip strength ratings, which one is in kilogram, and another one is for female, the female for our female classmates. Okay, so you can how to use this chart. You can see from the age, from here and you can see if you are 31, then the normal range of your grasping power is 36 to 55 in kilogram. If you are over 55.8, you are strong. But you are less than 36, it's weak. Okay, this is for the males. And this one is for the female. For example, if you are 31, then your grasping power of female is around 21.5 to 35.3. If you are less than 21.5, then your grasping power is not strong enough. We call that weak. OK， 大家可以自己圈一下，给自己一个 rating。So you can see from these two charts, you have a grasping function in the right side and the left side is normal, or weak, or strong. OK， 可以吗？ So that there comes different standard from different age and different gender. Okay, so you will get a number of your grasping function in right hand and left hand, and which you can also have the chart to see if you are normal or weak or strong. Okay, if you are weak, don't worry, you have to train your muscle power. What muscle power? Grasping muscle power. Okay, if you are normal, congratulations, you can keep it that way. But how come you are strong? You are strong. Remember not to squeeze your classmates too hard. Okay? OK， 这是 grasping function， 好不好？大家自己有左手有右手。OK， this is the rating of your grip strength. OK。Okay, let us see the second one. This is the prehension. We call that prehension. There are 6 types of prehension, but 3 of them are important. One is the tip prehension like this one, and this one is 3-jaw chuck. 3-jaw chuck is important for writing. If you are holding a pen, if you are holding a pencil, if you are holding a pen, it is important to have a 3-jaw muscle power enough. And the last one is the lateral prehension. Lateral prehension, we have told you that it is also very important for open the door and using the key and taking the money. Okay, counting the money is lateral prehension. So that lateral pinch, we can I think all of you have tested your pinch muscle power. Okay, and then we can also I've said that before, the pinch. Okay, this one is the normal standard for thin pinch. This one is for thin pinch. And this one is for the lateral pinch. We also call that common name in key pinch. Key pinch. Okay, now you can check in this chart if you are normal. Okay, this is the right hand, this is the left hand, this one is the mean, and this one is for men, and this one is for women. Okay, then you can look at this chart to see if your key pinch, we call that lateral pinch, is good enough or within the normal range or between the standard or standard error. Okay, for example, if you are male of 31 years old in the right side, you will have a mean key pinch power of 26.4 or 26.4. Okay, if you are for example, you are left side, you have a 26.2 in that side. Okay, so that everybody gets your key pinch power, and you can check this chart to see if you are in the normal or standardized norm. OK， 大家可以对照这个表，看看你的这个 lateral pinch， 好，就是这个捏力的这个东西是不是在正确的范围里面，好不好？
The number is in pounds or in children?
好了，
The number is in pounds or in children?
Let us see. Pounds. This one is pounds. Pounds. Oh. Okay, everyone got your pinch power, lateral pinch power? (可以吗？可以。你比如说你是几岁？30岁嘛，右边左边嘛，你可以对一下，对照你是低、中、高还是在平均嘛，对不对？男生跟女生，女生会稍微再小一点点，小一点点。Okay, does everybody get your rankings? The means or low or high? Okay. So what is the importance of grasping and pinch power? And pinch power. 为什么我要跟各位讲这个东西 ？If you are designing a prosthesis for a man like you, with similar height, with similar power, with similar gender, what is the reference you should take? It is the muscle power you should take for the training purposes. OK， 就是说你们要怎么样去训练病人比如说今天我是30岁的男生，我要帮这样的病人，我训练他的这个 grasping power、pinch power 这个东西的时候，我要用基于什么东西？基于这个标准值去设计，你就不会超出太多。这样知道吗？为什么要这样子设计？就是 different the pinch power and the grasping power comes differently from different age, different gender, and different conditions. If you are right-handed, the grasping power and pinch power will be bigger than the left side, right? If you are left-handed, the pinch power in left side will be higher than the right side, right? And normally, the male, the power of grasping and pinch will be higher than the female. The older, the muscle power is higher than the younger, right? So it is important, it is useful in setting goals of muscle strengthening exercise using these norm conditions, OK? 这样大家知道所以我们这样在设计的时候，在不同的年龄、不同的性别、不同的性，还有不同的左右手、惯用手的时候，你就可以设计不同的训练的目的，这样知道吗 ？OK？ Okay, I think that's the style of this class. Okay, any questions?大家没有什么问题？我们在设计这个上肢的特别是上肢 prosthesis 的时候，力量的设计其实很重要。力量的设计其实很重要。It is important to design the goal of strengthening exercise while designing or training a prosthesis. Either in adults or either in children. 我们不管是设计大人或者是小孩，这个时候他的握力、它的捏力，这个都很重要，都很重要。为什么要请大家设计题？就是有经由这个测过自己这个力量之后，那你再去设计或者是使用这辅具的时候，你就会知道。For example, if you are using a hook device like